Hello, my name is Gerhard Hesse. I'm a Rolfer since 1984. I taught my first anatomy class in 2002 and my first Rolfing class in 2007. It's many years ago I visited Hans Fleury, a former Rolfing instructor colleague in Zurich, in Switzerland. And we discussed about the situation of the pelvis, shift, tilt, and how is the whole body organizing or adapting to the shift and tilt situation. And then Hans said to me, Gerhard, I most often feel the right ilium going down, so the torsion of the right ilium. And I went home, and indeed I found this. And as I'm a good German fellow, I immediately had a good explanation. Because the ascending column, I thought, has to do much more work, heavier work than the descending, the sigmoid. So it starts to adhere, and so the iliacus reacts and creates this counter torsion of the right pelvis half from the coxar. And I digged in the right iliacus, and there was some change, but not this fact that the right ilium is going down, larger. That was also the time when I started to do dissections in the Anatomical Institute in Vienna, at the university. And I could not find these adhesions. So the fact was still there, but my explanation was gone. And that was the moment when I decided to have a brief look to the situation of the pelvis. So my question is there symmetry? We know that the viscera are asymmetrically. We know we have symmetrically 2 legs, 2 arms, 2 eyes, 2 ears, and so on. But how far the symmetry goes in the skeletal system? And before I give another explanation, I thought, first I want to describe what is. Then I try to configure it, all relationships, and then I come to some conclusions where we can improve a situation. So before we go to the slides, these are the words, the shortcuts, the abbreviations I use. Spina iliaca anterior superior, SIAS. SIPS for the spina iliaca posterior superior. The sagittal distance from SIAS to SIPS. The lateral distance from SIPS to SIAS. Adductus and abductus. ADD, adductus, abductus, ABD. Then I said, okay, I will build a box. And this box, you see here, it looks a little like a mid-8 torturing instrument. But actually I could measure the 2 spina iliaca posterior superior, the 2 spina iliaca anterior superior. And I first also tried to put a clear point on the ischial tuberosity. After 2-3 tries, I forgot the tuberosities because they are uneven, round shaped, yes. But having 2 points, it creates a line. 3 points creates a plane, and 4 points create a space. So I put the people in the space, yes, in the box, yes. So like the skeleton here, yes. But then I put all my clients in this box. I put all my friends, all my family. Everybody had to go in this box. And so I measured and put the people in, put the sticks there, measured the right spina iliaca anterior superior, measured the distance, anterior, posterior, and lateral, and then put it away. People got out, put it again. So I had this 4 point in space. And what came out was very interesting. Yes. In most of the people, we find an enlarged lateral distance. That means the right ilium is larger to the side than the left one, or also the anterior posterior distance. That means the right ilium is bigger, it's increased. That's what we till then thought to be just a pelvic outflare or a torsion of the pelvis is an increased right ilium. The bone is bigger. Then I had a lot of data from my clients. Yes. So the possible just pure osseous pattern is about more than half of the people. Some osseous and maybe also some physiological, that means also a torsion on the right ilium is another part. But on the left, yes, there were only very few people, 15%, 15 out of 100, that were not fitting in this torsional pattern, this increased right ilium pattern. Then I looked how the situation of the rotation of the pelvis is. Almost everybody has the pelvis, the right pelvis, anterior rotated. And I looked how this increased ilium is fitting to the gender. there was no difference, not to what's fitting the pattern, male and female, the same relations, and where the pattern is not fitting, male, female, the same relation. I also had a phone call to Australia and had asked them to look at this. So I thought maybe this is a Coriolis force that turns the earth, yes? But it's not, it's the same. Then I did another test. I looked which leg is shorter. So I want to see which leg is longer. And it's not so much that really know which bone is longer, just the whole leg in the body. So I look if its legs are quite in a straight situation with the upper body. Take the feet, do a dorsiflexion, and then I look from above and see which heel is more inferior. And here we find it about 3-4 millimeters more inferior to the left heel. Thank you. And I look, yes, the pattern, is it in a relation to the shorter leg? And no, it's the same. Also, people with the left leg short show the same increased right ilium. With the right and shorter leg showed the same increased right ilium. I did it with kids too. For these kids, they did not like to be in the box, but so I used a so-called pelvic circle, a measure instrument for midwives, where I just can measure the distance. So with these kids, I could not see if it's an anterior, posterior, or more a lateral increased, but it's increased in the same relation. Yes. So out of 10 kids, 8 had the increased and 2 not. So there's a Austrian physician, he received the Nobel Prize. He said, in the domain of life, there are no forms by chance. Maybe the form of the Matterhorn is by chance, but the form of a heart, of a kidney, of a rabbit, it's not by chance. There are some processes behind that create these forms. So in the sense of Rolfing, function creates a structure. That means if I use my body in a certain way, it builds up my structural situation. But that what we found here in this right increased ilium belongs more to the human organization. It is not a structural development, but it's organization. It's evolutionary growth, not within our lives. What I found then with all the data from my clients about major knee problems, hip problems, scoliosis, slip discs, this was really a little shocking to me, because this 20% of people with a shorter left leg, 8% from them had these problems, this kind of rotational problems, but only 5% of the people with the shorter right leg. So the conclusion is very clear for me. The shorter left leg is really a troublemaker. So I did another test. I was looking if the abductors or adductors more limiting the side tilt of the pelvis. This test looks like this. In this test I look if the abductors or adductors limiting or restricting the side tilt of the pelvis. So if I do a side tilt to the right, where do you feel the limitation, Andreas, the pulling?
In the left leg inside.
In the left adductors, if I go on this side.
In the right leg.
In the right adductors. So adductors limitate this side tilt of the pelvis. Thank you. Most of the people show the adductive limitation, but this depends how far you put the legs apart. If you put them wider, the adductors limit fast. If you put them closer, more people have also abductive limitations. But what was really interesting, that some people showed limitation on the left leg, at the adductors and the abductors only. That means the side tilt to the right, they had the limitation on the left adductors. A side tilt to the left, they had the limitation on the left abductors, always on the left. And all these people who showed this ABD, ADD imbalance are left leg short. Not everybody who is left leg short shows this ABD, ADD imbalance. Because if you're a good Rolf body or do a lot of yoga, you are stretched enough. But everybody who showed this ABD and ADD imbalance were left leg short. So, concluding, we can say the pelvic pattern of the larger right ilium is mostly osseous and to some degree osseous and also maybe physiological. The shorter left leg, if the right leg is shorter, leave it, if it's not too much. If the left leg is shorter, do what you can to elongate. And what we have to do, we have to change the relation. So we should not work on the same side, on both sides, because we have to work different on the sides, because we want to change the relation, the rotational relation, the length relation, so we have to work different. And we have to equalize the adductor-abductor. situation, because it's really 100% related to a shorter left leg, yes, and 100% related to rotational problems. Means all the people who had showed this ABD, ADD imbalance had some of these rotational problems: major knee, slip disc, coxarthrosis, scoliosis. And if you go on thinking a bit, yes, that all severe scoliosis are lumbar left convex. I don't say that all scoliosis come from a shorter left leg, but a lot of these so-called idiopathic scoliosis are in relation with a shorter left leg. So, what does it mean for our daily work? Yes. So we can teach the people with a shorter left leg not sitting, not cross over the left leg over the right, but the right over the left, to loosen the right hip joint. And in standing, they should really load the longer right leg to have the left leg open and free. When we're working, it's not only in this area, we have to work up the lateral, we have to up the diagonals, we have to work from superficial to deep, because it's always reflecting within our organ system, which is asymmetrically. And when we do some patterning, we have to respect the more outward rotated right leg. If we force this body in a symmetry that is not existing in this body, we create a counter reaction in the upper body, so this is meaningless. So the right leg, usually when we have a strong lateral, increased ilium, it's more in a lateral rotation, and the T-back goes more in an internal rotation. And this is not what we can change, because it's the larger right ilium that creates this. If the bones are too different, there will not be a lot of structural change, because the body has to adapt. But let's go easy with it, because if we Rolf the people, the body becomes more fluidity, becomes more adaptive to any problems. So they have benefit a lot of this. Yes. And if we think about the far-reaching possibilities of understanding, more research has to be done, definitely, of the problem that the shorter left leg creates, yes, for example, in hip transplantation, or how we deal with scoliosis. Yes. This is still far place to go. So our vision is the upright human being, graceful in posture and movement, with this asymmetry also in the skeletal system. That does not mean that we are random. Yes, most people have the right leg anterior. The right eye is more posterior in almost everybody. That means we're not only lordosis kyphoting in the spine, but there's also a rotation, a side bend. It's a spiral. We're all spiraling. If there are problems in this situation, our job is to elongate the spiral, which maybe in scoliosis really clear, it puts together. So we have to make it long again, open it to ground and space. Thank you for your attention.